Okay, dear Chairman, dear ladies and gentlemen, you already heard some data by Professor Sharma on the Interobserver variation of pathologists, and you heard that is very poor. So I will try to enlighten some of the facts around this and maybe enhance your understanding why there seems to be a problem. If you go into literature, this is probably the most compelling list of most compelling interests you can find. Barrett seems to be the electrical toy train. Everybody is interested in Barrett's, for what reason ever. Surgeons, gastroenterologists, pathologists. But to bring it down to a more reasonable base, Barrett's carcinoma is, at least in Europe, it's a rare carcinoma compared to colon or gastric cancer. So why is there a problem? As I already told you, the criteria, the first is that the criteria that are available in the literature for making the diagnosis of dysplasia or carcinoma are not validated nor accepted worldwide. And there is definitely a lower threshold for carcinoma diagnosis in Japan, and there's a higher threshold for carcinoma diagnosis in the US. But it has nothing to do with inexperience or stupidity or something like that. The colleagues are very consistent in calling something low-grade dysplasia only or high-grade dysplasia only and not carcinoma as compared to Japan. In Europe, there seems to be something in between, depending who trained the pathologists. So if it was somebody that was more addicted to Japan, then it's probably a little bit lower, and if somebody was trained close to the US system, it is a high threshold as well. And we have different medical systems. In the US, and please, in the audience, correct me, the colleagues, there is a strictly outcome-driven medicine performed. That means the outcome is everything. In Europe, especially in Germany, it's just, there it's very clear that you can make a wrong diagnosis and you can make a wrong decision. This is not the issue. But you have to have all documented things together. The patient needs to have signed all these papers, and that's important for Europe. So especially in our country, Germany, it's no problem to make it to put it in very easy words, to make a wrong diagnosis. It's just the way how you deal with this diagnosis, that is important, and that is completely different from the US. And therefore, there are also these historical differences in these different systems. The Vienna classification was a very good idea to group therapeutic groups together to shrink these inter-observer variations, but they never tried to assess the real reasons for these variances. Anyhow, it all started already with a non-neoplastic Barrett's, with a double muscularis mucosae. If there is neoplasia, there are three different systems. The last two on the right-hand side are very similar systems to grade the depth of infiltration, to assess the depth of infiltration in Barrett's esophagus. It's very complicated because of the double muscularis mucosae. Some pathologists never know in which level they are, and then they call a mucosal carcinoma already submucosal, and that would lead to surgical interventions. Why is that the case? Well, in Barrett's, the squamous epithelium is not only replaced by another epithelium, it's replaced by columnar epithelium with stromal tissue and a new muscularis mucosae. And that is the problem. And that you can subdivide according to the anatomical structures, and squamous cell carcinoma is subdivided into M1 to M3, but not M1 to M4, since there is, in squamous cell carcinoma, there is not a doubled muscularis mucosae. Where does that Barrett's come from? The most recent theories are stem cell concepts, and they go along with the concept of multiple cell lineages that are present. So it's not only one cell lineage that produces these goblet cell containing specialized intestinal metaplasia, it's several ones. It's gastric ones, it's intestinal ones, and that makes it so difficult to find or identify the real precursor lesions of Barrett's. The background mucosa of Barrett's is also very important. There's only one study from Amsterdam that shows you in 100% of the cases in rather large tumors that you find intestinal metaplasia in cases with Barrett's adenocarcinoma. In the US, there seems to be more cases positive with goblet cells than in Europe. And in Japan, for the other extreme, there are only very few cases that have intestinal metaplasia. So it's not very clear what's going on here. And we know already that Barrett's or columnar metaplasia in the esophagus without goblet cells also show the same DNA abnormalities like goblet cell containing epithelium. So again, there are multiple cell lineages, gastric, intestinal, and even mixed ones. And our terminology is also a problem. It was the term dysplasia was first used in 1923 by Eduard Krombacher from Budapest. And what he said was basically, he defined the term as cells that look abnormal under a microscope but are not cancer. This is the best definition we have. We do not have anything better than this. And that's very interesting. And all our attempts with low-grade and some years ago moderate dysplasia, that should not be used anymore, high-grade dysplasia, that are only attempts to get a risk stratification out of the histological picture where a certain lesion might drive to. And here is an example of a very well-working diagnostic criteria in Barrett's. But these criteria are not widely applied, nor they are not validated, and they are not accepted worldwide, and this is the problem. There is no proof that this is right or wrong, and therefore there are differences. And we have different methods of reporting. We have grade versus and extent of a lesion, and then we have low grade versus high grade. We have grouping of therapeutic groups together, and this is very, very complicated. It already led to the situation that studies are not comparable anymore worldwide. And what we would need is a uniform approach, maybe a proforma, how to report on dysplasia in Barrett's. We may need, in some cases, a second opinion if people are not very informed about certain lesions because they have just a very little number of cases and they cannot really train on. And hopefully we will get some biomarkers in the future. And if we now look in the literature for the natural history of low-grade dysplasia in Barrett's, it turns out that most of the lesions are believed to regress. If most lesions regress, then you have to question yourself whether you have a whether you have a misinterpretation from regenerative changes into neoplastic. And that is probably the case, because in this very interesting study by Wouter Curvers from Amsterdam, it showed that after expert pathologist agreement, more than 40% of the lesions progressed to a higher grade of neoplasia, so high-grade dysplasia or carcinoma, whereas in the normal literature, it's just 6.7%. So there is something wrong with the diagnosis. And in our case, in our series in Bayreuth, we came up to the very same 42%. So we had 6% high-grade dysplasia, 36% carcinoma. So independently, we also got these 42%. This looks very fine because we could see that we were independently doing the same work like it is performed in Amsterdam, which gives us more confidence for daily work. But if we confirm 42% that have a higher risk to progress, what's with the other 60%? So what we tried to figure out was we counted the neoplastic tubules and came to the conclusion that if we have more than 5 glands in a biopsy involved in the neoplasia, then there is a high risk for carcinoma development within the next 12 months. It's almost 3/4. And if it's just representing 1 or 2 glands or 3 glands, less than 5, so to say, it's the other way around. So this may help us in the future that we can identify from biopsies what's really, really going on. The Interobserver variation is acceptable, kind of, if you involve at least 2 GI pathologists. And it becomes even better if you involve 5 GI pathologists. We could also set up a study involving 50 GI pathologists, and then it's probably even more relevant, but this is not feasible. So, second opinion, yes, but send it outside. Do not go to next door. Ask your pathologist to send it outside to another institution. And they know the addresses to send the cases out. What's with high-grade dysplasia? Well, high-grade dysplasia, it's almost not possible with the criteria that are non-validated, not accepted whatsoever, to distinguish between mucosal carcinoma and high-grade dysplasia. So this does not work. This was one of the ideas behind the Vienna classification, also to group this together, because both can be removed endoscopically with no huge dangers. But the problem in these cases is that the carcinoma is defined in the WHO classification as a break through the basement membrane and with a single tumor cells, desmoplastic stromal reactions, and all these things. The point is that well-differentiated tumors build up their own basement membrane. You will never see single tumor cells nor desmoplastic stromal reaction in very early mucosal or early submucosal cancers. So this does not work. And this is from the WHO classification. In our own series, almost all cases of high-grade dysplasia turned out to be cancer. But this is kind of an academic discussion because we have a very low threshold to call something cancer. So it needs to be treated. The molecular markers in the literature did not do any good so far, especially when you take out single markers and ask whether this gives any benefit to prove your diagnosis. This does not work, regardless which marker you take from this list. But if you have a 7-marker panel model, each marker that is abnormal in this panel will add another probability that something is really developing neoplastic here. But in a single case, this might be very, very difficult to use. So it comes also back to the H&E routine stain. So in conclusion, and this is something Patrick Sharma has also already showed you, low-grade dysplasia is often overdiagnosed. So in Barrett's, we are fighting with over- and underdiagnoses. In the stomach, it's mostly underdiagnosis, but in Barrett's, it's over- and underdiagnosis, and that makes it extremely difficult. But you can help your pathologist, and that was also something Patrick Sharma already addressed with the inflammation in these lesions. You could prescribe some proton pump inhibitor prior to the controls for some weeks, and then the inflammatory changes should be gone after these 4 to 8 weeks, whereas neoplastic changes should be still there. That could help your pathologist. And you need the second opinion in cases where you're in doubt or the pathologist is in doubt about the result. And please keep in mind, if you do not see anything in a biopsy, in your endoscopic procedure, and you get something back from the pathologist as carcinoma, but you have not seen anything, then be careful with the diagnosis. If you get back, if you have seen a lot, ulcerated lesions, and you get back low-grade dysplasia, this is not possible either. So please question this and try to relate your endoscopic findings with the histology you get. Otherwise, you will be completely lost. And you have to solve this problem with your pathologist to get the best cooperation out of this situation. And the molecular markers in the future hopefully will help us to identify those patients that have higher risks and need the follow-up or need closer whatsoever. And all the others could probably go, because the majority of Barrett's patients will not develop cancer. Thank you.
Thank you, Michael, for your excellent presentation, your critical remarks and important recommendations. Now we will discuss all the lectures at the end of the session. We heard a lot about diagnosis and indications for treatment, and now we proceed to various